complications that lead to revision surgery following adult deformity. So PJF is certainly one of the leading causes. Infection is another. And I think the third most frequent is revision for rod fracture with non-union. And this is, again, a topic that we've focused on within the ISSG over the last several years. And I think that's informed some of the decision-making that I have with respect to this complication. So here are my conflicts. None of them really relate directly to this topic. So rod fracture does remain a significant concern following fusion for adult spinal deformity. And I think when we say rod fracture, I think we're really talking about a situation where there's been a non-union or a failure of fusion. So when the fusion heals, typically the rods don't fracture, or if we do see a rod fracture with a healed fusion, really it's a clinically silent phenomenon in most cases. So it's not symptomatic usually, I think, unless there is significant residual motion due to a non-union. And here's some of the data out of a recent series, some of these from single centers, and then at the bottom, Justin Smith summarizing ISSG data. And you can see it occurs in up to 23%, certainly hovering around 10%, even in the most accomplished and experienced centers. And when we found that when we did a 3-column osteotomy, a PSO, the rate goes even higher. So depending on the procedure performed, rates somewhere between, let's say, 10 to 20 or even 20 or higher percent. And as for most complications, we can identify some of the risk factors. Obesity is one because of the extended, presumably because of the higher mechanical loads. Medical comorbidities is another, again, presumably because of effects on bone healing, let's say. If we're operating in the face of infection, or if we develop infection postoperatively, that obviously reduces the ability to get a solid fusion. Revision situations we know are harder to get solid fusion, and then 3-column osteotomy that we've already talked about. I'm a believer in BMP for adult deformity surgery. This really doesn't project on these screens, does it? So the lack of BMP I've put as another risk factor, and we actually did show that within the ISSG data, that centers where surgeons used BMP compared to centers where they didn't, the BMP users had a lower rate of rod fracture and non-union, and there was a very variable dosage used. I don't think that's been agreed upon or standardized yet, but does seem to be a feature. And then I think the other one that we have control over in our own practices is rod diameter and the material from which the rods are manufactured. So the incidence of this complication typically peaks around 12 months and then between 12 and 24 months. And this data does not include follow-up to 5 years. I have seen in my own practice now a handful of patients, and I think it's less than 5, but it's nonetheless a phenomenon that even after 5 years you can see rod fracture that becomes symptomatic. So that's an argument, I think, for long-term follow-up in these patients, although I suspect that if they develop that complication, even if you haven't scheduled them, they're going to find their way back into either your office or another surgeon's office once that occurs. There's a few that also are sort of incidentally found that the patient has been relatively asymptomatic and done well, and a rod fracture appears on a long-term follow-up. I've certainly seen that as well. But by far, the majority that seem to be symptomatic occur within the first 2 months following these surgeries. And this is ISSG data, again, out of Justin Smith's paper that shows that PSOs are the most frequent location of the non-union or rod fracture. You can see the black box in the middle shows you where that's at, and the long row there in the middle of this slide are patients who suffered a fracture at L3, and I think we'd recognize that's the most common level of 3-column osteotomy. But beyond that, we can say that it does tend to be also a feature of lumbar spine more than thoracic spine, and lower lumbar spine more than upper lumbar spine, if we say from L3 down. So I think many of us are aware there's a fusion grade classification, and this is used mainly for research assessments. And this came out of WashU a number of years ago, looking both at interbody fusions and at posterior column fusions, and tried to assign a grading scale to the radiographic appearance on plain X-rays for when a fusion is clearly solid versus clearly failed. And they did include actually rod fracture as one end of this spectrum, suggesting a clear non-union when the rod fracture had occurred. But the data to support the validity of that classification is really fairly limited. And we really don't have a gold standard radiographic verification for ultimate fusion. So even CT scans, which provide much more detail than plain X-rays, are not sufficient to really know for certain that a fusion is solid. And I think given that, an approach that seems valid is that rod fracture may in fact be a proxy for a true non-union. So unless we see a rod fracture, the argument would be that we don't know there's a non-union. And conversely, even with unfractured rods, we really have no way of knowing that a fusion is truly solid. So I think if we take that as an operating principle, that's a useful approach. And we tried to apply some data to that, again, with a hypothesis that rod fracture is more important to clinical outcome than fusion grade is. So we can look at these radiographically, we can hope and believe that we've got a solid fusion, but we really don't know that. And conversely, when we see rod fracture, that's going to be more of an indicator of how the patient is doing clinically. And I think we can appreciate that. Let's say we have solid rods without a solid fusion, that patient can still be relatively asymptomatic because the mobility of the spine is limited as long as the rods remain intact. So when we applied this to our cohort of prospective operative patients for adult spinal deformity, we found that, in fact, that we could support that hypothesis. So the bars on the left here are those that were graded as complete fusion or incomplete fusion by the Washington UW or the WashU grading scale. And you can see that those ODI results are essentially identical. On the right, however, are the results of patients that have rod fractures. So once the rod has fractured, they seem to have a higher level of symptoms. And the very far right column are those for whom we performed a revision fusion. And again, not too surprising, we're reoperating on the patients that are most painful. But again, all of those patients also had rod fracture, not just a low radiographic grade. So we really don't operate on radiographic classification of fusion, but on symptoms, and in particular patients that have fractured rods. Similarly with SF36, this of course is the margin of difference for statistical significance is, or for clinically important, minimally clinically important difference is much lower for SF36 physical scale than for ODI. These did have some of the same patterns of statistical significance, not quite reaching statistical significance, but a clear trend. And the SRS instrument, similarly, this is statistically significant. Again, a much smaller spectrum of difference on numerical difference. Similarly for the activity subscale of the SRS, and for the pain subscale on the SRS score. Satisfaction score is relatively unaffected by this. Again, I think we know that the drivers of satisfaction lay more in the realm perhaps of interactions with the physician and care team and hospital than they do with the actual clinical outcomes. And this was one that I found was interesting. Some of you may be aware of this Lumbar Stiffness Disability Index is a questionnaire that we put together now, I think almost 10 years ago, and have been using in a small set of studies to really assess not how pain affects function, but how patients perceive stiffness to affect their function following lumbar fusion, with an eye towards answering the question that I think a lot of us hear from almost 100%, I think, in my practice. My patients want to know how their stiffness or how their spines are going to behave, how they'll be affected by stiffness. And it turns out that even though the rods fracture, presumably creating more mobility, the patients actually perceive more limited limited mobility and more impact as a result of stiffness. And that's one of the things we've found with that questionnaire, is that there's a correlation between pain and stiffness. So patients that are in pain really don't use their low backs in a substantial way and perceive that as stiffness. And the end result of that is that they don't necessarily find that they are more impacted by loss of motion following these long fusions. But interestingly, when the rods fracture, you would think that they would have more mobility. They're reporting less mobility as a result of that. So tips and pearls to take away from some of these thoughts. How do we avoid rod fracture and pseudoarthrosis? One, I think, as I've already talked about, is to use osteobiologics. I think this is increasingly a subject of economic discussion within hospitals, and I think many of us are being pushed to use less bone morphogenic protein. We may have more economical products available soon, but I think still BMP2 is still, in my mind, and I believe as supported by data, the best available biologic in terms of stimulating fusion. And again, this is not a one-level TLIF. I think you can make an argument in a shorter fusion not to use bone morphogenic protein. In these longer constructs, I think economically over time, whether it's acceptable to your hospital's bottom line in the index procedure over time for these patients, I think it does reduce costs as it reduces the risk of reoperation. I like to use an ALIF at 5'1". I know Munish is an advocate of that in many cases. I certainly do that if there's a plump disc there, or I more commonly will do it at least with a plump disc, because I believe I get a better access to the disc, better clearance of the disc, and presumably a better fusion. I tend to do interbodies at all laminectomized levels. Right now I do that either as a TLIF or if the procedure is going longer than wanted, or we encounter heavy scar, or our blood loss is getting high, I will lock down the posterior implants and come back at a second stage, usually 4 weeks later, and do XLIFs or some other sort of access to the discs and complete the interbody fusions at that stage. I have increased my rod diameter to either 6.0 or 6.35. I think that's going to help. Again, that's just an issue of mechanical strength. And I typically now include bilateral pelvic fixation. For a time, I used unilateral fixation in some cases, but I've found that I think I have a better construct and a better durability of construct with bilateral pelvic fixation. And I've gone to spanning all 3-column osteotomies with at least 3, if not 4 rods, and the T-lifts the same way. So if we've taken a facet and back, I will span all of the T-lifts that we've done with a 3rd rod, typically as an outrigger, and I'll show some examples of that. And Munish Gupta, again, I want to credit with the concept of outrigger rods for 3-column osteotomy closure. So all of our spine implant kits now have a lot of modularity. I think we'll see even more modularity in coming systems with removable heads and dual heads, so that we won't have to put adjacent fixation around the actual pedicle screw heads. And this is an example out of my practice. There's a patient I operated on, I think about 4 years ago now, in Oregon, and a really fairly large gentleman with kind of a potpourri of prior spine surgery, but clearly with issues of flat back and sagittal imbalance, as well as pseudoarthrosis at his upper level of fusion and at 5'1", actually. And we revised him with an ALIF at 5'1" and then a PSO at the L3 level. I augment the PSOs in most cases with an interbody above the PSO. That's an extended PSO, and it moves up the Schwab osteotomy classification grade by 1. And I forget what the number is, but a PSO without taking the disc above is 1 grade, and then the next grade up is a PSO with a TLIF or interbody fusion above the PSO. PSO. I feel I get actually better angular correction with that, and in addition, I think it gives us a better chance of healing the construct. I really think in most cases you need to do interbodies both above and below a PSO. So in this case, we had a solid fusion at the interbody below the PSO. If I don't have that, I will typically come back and do as a second stage or as part of the index and operation an interbody at the disc space below. And I think the problem is that as we do the PSO, back in the day when PSOs were first being described, people were aiming for closure of the lamina tightly together to get bone-on-bone apposition in the posterior column. I think most of us have gone away from that more recently because of the threat of neurologic compromise. And so we are typically I typically leave a gap in my posterior column following these osteotomies, so we can no longer rely on the stability of the posterior column to protect the fusion. And if you think about then what that means, even if you have a solid posterior column to the level of the osteotomy, if the interbody space is open, once you do that osteotomy, you have, again, mobilized that disc space below your osteotomy. So I don't know if I'm making that clear. Hopefully so. I think it's a real phenomenon, and I've seen fractures in my own patients, rod fractures, as a result of that phenomenon. So in this gentleman, what we did was do the osteotomy. I did a TLIF one level above due to stenosis, and then we've put on 2 outrigger rods extending below the S1 pedicle screw, and this is typically where I locate the outrigger, is between the S1 pedicle screw and the pelvic screw, and the thinking there is that you're not taking up space for your fusion. You're putting it at a place where you don't necessarily need biological fusion below the S1 pedicle screw, so it's a relatively limited harm. And then I put it also at the level of the TLIF. Again, there the facet has been taken, so I'm less focused on trying to get a solid fusion in the posterior column at that level. This is another example. This is a woman that really had 2 problems that came in. She does have proximal junctional kyphosis, which had been sort of partially treated with an anterior procedure above a long construct. That really wasn't troubling her much clinically, but she was having terrible features of stenosis and very destructive arthropathy down at the 4-5 disc space. You can see there. This was a long construct that ended at 4. She had a prior fusion actually from 4 to the sacrum uninstrumented, and this is, I think, a good argument for extending your posterior instrumentation across all levels of fusion to make sure that we don't run into this fracture through the fusion mass as this lady encountered. So we revised that with long rods and back and an A-lift. We actually did a corpectomy of 5 there. You can see, and the CT scan showed that there was more destruction of the 5 vertebrae than was really appreciable. I didn't think that we could do 2 separate discectomies with success. So we took all of 5 out in the front and then turned her over and did the posterior construct. You can see we used short screws at the L5 pedicle and an outrigger spanning the entire construct from S1 to well above the corpectomy. Finally, this is an example of how I now manage rod fracture in most cases. This is a woman that we operated on for really spinal stenosis and did a T10 to the pelvis fusion. This is one of my own patients that developed a fair amount of proximal junctional kyphosis, kind of a hard x-ray to look at, but this really never bothered her. She noticed it, she was aware of it, it was not painful, and she was very happy with her result for a number of years. And she's one of the patients I was describing that came back at 5 years with a new fracture of her rod, and it was actually just after her 5-year follow-up. I'd seen her for 5-year follow-up. She was very happy. A few months after that, she came back with new onset of pain and a pseudarthrosis at the level there. 1 pedicle screw left out. I can't remember why I did that. I suspect that we tried to place the screw and just were never able to satisfactorily locate it. But that was the level of her non-union, and I use a Catscan typically to try to define this. In her case, I felt we had solid fusions above and below that level, and So I will typically do this in a fairly minimally invasive method, going in with, however you do it, a lateral interbody approach, in this case transpsoas approach, and then turned her over and put outrigger rods with 2 points of fixation above and below the level of the rod fracture, and she's gone on so far to have a nice result from that intervention. So in conclusion, rod fracture pseudoarthrosis still remains one of the significant reasons, significant complications leading to reoperation in adult spinal deformity. I think avoidance and reduction strategies include biological and mechanical approaches. I didn't mention Forteo. That's yet another pharmaceutical approach that in patients with low bone density probably accelerates and improves union rate. Management requires definition of the non-union when this occurs, and I think we can hopefully employ less invasive revision strategies than maybe we've used in the past, and retain and augment alignment at revision. And that's yet another issue. If you have a patient that may be slightly flat, or I remember one patient in particular that had a very high pelvic incidence, that we had really, for her, an excessive lordosis. She didn't like the extended lordosis that we gave her, so she wanted slightly less lordosis. So this is an opportunity to tweak your sagittal alignment if that's something your patient has been struggling with. And with that, I'll take questions.